So today I'm going to talk about diagnosing asthma, putting all the pieces of the jigsaw together. I'm Dr. Brian Litworth, head of the Scottish Centre for Respiratory Research at University of Dundee Nine Wells Hospital. So these are my disclosures, which may or may not be relevant, rather boring, so I'm going to move on to the next slide. Here's the batting order, which I'm going to address over the next 20 minutes. I'm going to talk about exhaled breath nitric oxide, FeNO, airway hyperresponsiveness, AHR, spirometry and oscillometry, and then try and tie things together for you. The asthma triad has three key tenets. The first is reversible airflow obstruction, either spontaneously or a result of treatment like a beta agonist like salbutamol. Type 2 inflammation, characterized by the endotypes of activation and increased expression of IL-4, 5 and 13, and the presence of airway hyperresponsiveness, which can be measured on bronchial challenge testing. So if we move on firstly to talk about fractional exhaled nitric oxide, FeNO, this is mediated by increased expression of the type 2 downstream cytokine IL-13 and can be suppressed or attenuated by a variety of treatments, including corticosteroids, biologics, including dupilumab and tezepelumab, and to a much lesser degree by anti-IgE or leukotriene receptor antagonists. So it's a point of care test that we can use to get a good on the upper airway, because the presence of either allergic rhinitis or chronic rhinosinusitis with nasal polyps can impact and give you higher levels of FeNO, as seen in this study, looking at patients asthma with polyps, AWMP, compared to asthma alone. And these patients had a higher overall type 2 inflammatory burden in the presence of unified airways disease. And the same was seen for the IL-5 marker of blood eosinophils as well. These are just some data showing that it's not just oral corticosteroids which can suppress eosinophils and FeNO, but inhaled steroids can as well. And you can see from this study of 217 patients that there is a nice dose response between low and medium dose inhaled steroid on both of these biomarkers, but no significant additive effect on top of ICS with a leukotriene receptor antagonist as montelukast. So what do I think about in the clinic when I see a patient with a high FeNO of more than 50 parts per billion? You could probably reduce that to 25 parts per billion as a threshold in a patient who's already taking inhaled corticosteroid. The first point is, is the patient non-adherent to an inhaled corticosteroid? If they already take one, or can they use the inhaler? That's probably the most important point, to be honest. Secondly, if they're on a biologic, such as dupilumab or tezepelumab, which suppresses downstream IL-13, are they actually taking it if they're on home care? Because just because you've got it in your cupboard doesn't mean that you're actually stabbing yourself with it. Has the patient been taking nitrate-rich foods? Has there been a recent undercurrent respiratory tract infection or an allergen trigger, for example, that could lead to it being elevated? Has the patient got upper airways disease? And the obvious question is as well, what's the other type 2 biomarker in terms of the blood eosinophil count? And the other thing I think about when I see someone with a high FeNO is that I need to suppress that type 2 inflammatory volcano as soon as possible to prevent an impending exacerbation. So we need to escalate treatment. Moving on to airway hyperresponsiveness, or AHR, there are two basic types of challenge or stimuli we can use. The first is direct, which by its name implies it works directly on airway smooth muscle. That could be methacholine or histamine acting on muscarinic type 3 or H1 receptors respectively, which causes the smooth muscle to contract. So that tells you about smooth muscle lability, but it tells you nothing about type 2 inflammation. Better and more physiological are the indirect stimuli, because these reflect more physiological everyday stimuli, and the one that we use is mannitol challenge. That's probably the most widely used. It's a commercially available test, which basically it's a sugar which osmotically lyses and fraps inflammatory cells like mast cells and eosinophils to release preformed mediators like leukotriene D4 and histamine, which then causes indirect bronchoconstriction. So this is the commercial mannitol challenge, very easy to use. It comes in a dry powder inhaler. You can see there, you put the capsule in, you puncture it, you inhale, and then 3 minutes later you repeat the FFE1. Very easy to do, and this is something that we've done in the community. Compare that, for example, at the bottom to a methacholine challenge where you've got all the hassle and aggravation of making up the dilution series, and then you've also got to have a dosimeter to deliver the nebulized dose, and you've got to calibrate that dosimeter as well. I know which one we use, and it's the one at the top, not the one at the bottom. We've pretty much given up with methacholine now. So what you do is you give increasing doses of mannitol up to a maximum dose of 635 milligrams with the dry powder device, in other words, a cumulative dose response curve, until you get a predetermined fall in FEV1, which is usually 15%. In severe asthma, we use the 10% threshold, which we have validated. So we would use a PD10 in severe asthma and a PD15 in other asthmatic patients. So this is a community study where actually we did mannitol challenge in a community setting, having established it's safe to do. And here we actually use the higher PD15 threshold, dose shown in milligrams. And actually, when you compare patients who were controlled or not controlled, according to an ACQ cut point of 1, less than 1 compared to more than 1, the latter being poorly controlled, you can see what delineates them very clearly is the mannitol PD15, which is 4-fold lower, or 2 doubling doses lower in the poorly controlled patients compared to the well-controlled patients. And for what it's worth, that was highly significant. FeNO was not significantly different between the two groups, and neither was FEV1% predicted. So you can see there, airway hyperresponsiveness using mannitol challenge, very close related to asthma control. This is a study, another community study in primary care, where we randomized patients to titrate the dose of inhaled steroid. We used a reference inhaled steroid, namely ciclesonide in this study. Over 12 months, there were 2 randomized groups. One got the dose of inhaled steroid titrated against airway hyperresponsiveness with mannitol, and the other group was a control group which got their ICS dose titrated against BTS guidelines, so symptoms, reliever use, lung function. And what this shows is the doubling dose difference in either mannitol or methacholine, because we measured methacholine at the same time out of interest, comparing baseline to endpoint at 12 months after ICS dose titration. And what we found was that ICS dose titration resulted in a 1.52 doubling difference in the mannitol PD10 dose after 12 months, which was highly significant, whereas for methacholine at the same time points, the doubling difference was only 0.61, which you can see from the confidence interval was not significantly different. So when you're using an anti-inflammatory drug which works on the type 2 cascade, then clearly using mannitol is much more closely related to type 2 inflammation than methacholine, which just reflects airway smooth muscle, as I was explaining before, and there's the proof of that. So if you're going to use mannitol and FeNO to rule out persistent asthma, which is commonly what we do in the clinic, so a patient's referred and they're not getting better on treatment, is it asthma or is it something else? It is important to use a treatment washout period to obviate the possibility of a false negative challenge and a falsely low FeNO. And ideally you want both together. So what we do is we employ an ICS washout period, a minimum of 14 days if it's beclomethasone, budesonide or fluticasone propionate. But if it's fluticasone furoate, i.e. Rolvar, then you really need a 4-week washout period to ensure the drug is washed out properly to avoid a false negative challenge. So that's something to bear in mind. For antihistamines and montelukast, it's 5 half-lives, which is about 5 days. So you have to stop those for 5 days. On the washout for LABA, because of the effect on airway smooth muscle, depending on whether it's a once daily or a twice daily labor would be a minimum of 24 to 48 hours. If you don't do that and you do the challenge while they're taking their ICS labor and it's negative, then you don't know whether it's a true or a false negative test. If it's positive, well then you're home and hosed. So that's the bottom line with challenge. And it's important to explain why you're doing that to patients. Moving on to airway oscillometry, conveniently, this is the technique. Basically, it involves imparting sound waves, in this case using the thoracist tremor flow, which is our device of choice now, just because it's more portable, easier to calibrate, better exportability, and less harmonic distortion. So here there's a vibrating mesh which imparts and superimposes sound waves at different frequencies on top of normal tidal breathing. And there are two components to what we measure, which is the respiratory impedance, which I'll come to in a moment. One is respiratory resistance, and the other is respiratory reactance. So if we move on to the next slide, these are the mechanics of respiratory impedance. So as I said, respiratory impedance is a measure of pressure in kilopascals divided by flow in litres per second. So kilopascals per litre per second is the unit of impedance. And there are two components of impedance. The first is the resistance, denoted by the letter R, the resistance in the pipe, which is the pressure required to drive that flow, kilopascals per litre per second. And the second is what's known as the reactance or compliance of the actual balloon in the distal airways. So this is expansion resulting from the applied pressure. So there are two key outputs which we use in the clinic. The first is the R520, which is the heterogeneity of the resistance between 5 and 20 hertz. Which is a measure of peripheral or distal airway resistance. And the second one is AX, or the area under the reactance curve, which tells you about peripheral airway capacitance or compliance, if you like. So these are some tracings of the oscillometry taken from the thoracist device. This actually shows the thoracist and the Jaeger master flow. We've put our master screen now into room 101 for the reasons I've already explained. Basically, lower frequencies travel further into the lung. So that measures the small airways. So higher frequencies will tell you about the larger airways down to the carina and maybe down to generation 6 or 7, but past generation 7 of the airways all the way down to generation of 23. If you want to know about that, what you need to do is subtract the total airway resistance, which is the resistance at 5 hertz, from the central airway or large airway resistance at 20 hertz. And if you subtract 5 minus 20, that gives you, by definition, the peripheral airway resistance. So this is quite a nice graph to teach the relationship of airway oscillometry, or AO, and asthma severity. Here we have healthy volunteers. Mild to moderate asthma shown in purple, severe asthma shown in blue. And you can see here that as you go from healthy to mild to moderate to severe asthma, there's a proportionate increase in total resistance at 5 hertz, but there's no change in central resistance at 20 hertz. So this is telling you very nice and clearly that asthma is not a disease of the large airways, it's a disease of the distal airways. And if you subtract 5 minus 20 hertz, peripheral resistance R5, R20, you get a proportional increase in peripheral airway resistance accordingly. And the same thing if you look at peripheral reactance as the reactance at 5 hertz or the reactance under the curve, the AX, you'll see a proportionate change in peripheral reactance or lung compliance. If we're looking at bronchodilator reversibility, these are patients with severe asthma, and you can see that their mean reversibility was 10%. For R5, R20, peripheral resistance, it was 38%, and for area under the reactance curve, AX, it was 53%. So the point of this is that if you're relying on FEV1 to detect reversibility, you may be missing significant bronchodilator reversibility if you are looking at FEV1 alone. So that's why if you're doing reversibility testing, I would say to you, you should also measure oscillometry as well if you really want to get a true handle on what's happening in terms of bronchodilator reversibility in the small airways. Airway oscillometry is closely related to type 2 inflammation. You can see that patients who have higher blood eosinophil counts have a higher peripheral resistance and also have reduced peripheral compliance in terms of a higher value of area under the reactance curve AX. But the point I want to make from this next slide is that really, if you really want to predict asthma control and exacerbation, so if you're sitting in your clinic and you want to get your crystal ball out, then what you need to do, if you want to predict whether you need to escalate treatment to prevent the type 2 inflammatory volcano from exploding and resulting in an exacerbation, is you need to combine both spirometry and oscillometry together to get the best predictive value. So if you look at an impaired FEF 2575 from spirometry, along with an impaired peripheral resistance R5, R20 from oscillometry, you can see the combination of both abnormal FEF and abnormal R5, R20 is associated with significantly worse asthma control as ACQ score and more frequent exacerbations. So don't take spirometry or oscillometry in isolation. The best predictive value is to combine them together. And here we can see the high resolution CT scan looking at spirometry and oscillometry. So this is looking at bronchial wall thickness in moderate severe asthma, in other words, airway remodeling. And here we can see the adjusted odds ratios and the confidence interval. To fit it on the screen, it's plotted on a log 10 scale. But the key point here is that FEV1 is not associated with a significantly increased likelihood of airway remodeling in these severe patients, whereas the R5, R20 is significantly associated. You can see the bottom end of the confidence interval for the adjusted odds ratio excludes 1 unity, and the same for AX. So FEV1 gives you a poor readout for the risk of airway remodeling. Oscillometry is much more sensitive in that regard. So just to wrap up, diagnosing asthma in the presence of a preserved FEV1, which I would define as more than 80% of predicted for age and height, may require using FeNO and airway hyperresponsiveness with mannitol testing too. To obviate a false negative mannitol challenge and to obviate a falsely suppressed FeNO, use a suitable washout period, especially for inhaled steroids, bearing in mind that with fluticasone furoate, that might have to be as long as 4 weeks to get an adequate washout. 3. Don't forget diurnal variability of peak flow, which is a very simple thing you can give to the patient with a prescribable peak flow meter, especially in the response to extrinsic triggers. And that reminds me that there is also a diurnal variability of FeNO as well, with values which are higher in the morning than in the evening. Fourthly, airway oscillometry AO is more sensitive at detecting bronchodilator reversibility in patients who have a preserved FEV1 more than 80%. And finally, as I've just shown you, and really crucially, combining airway oscillometry and oscillometry affords the best prediction of asthma control and an impending exacerbation. Thank you very much for your attention.